Good morning, everyone. Welcome to New York here at Mount Sinai for the monthly endovascular live case webcast. As usual, Dr. Krishnan and his team is bringing up an exciting and a challenging case like every month. The previous cases will be archived in the website, so you can go in and look at it, and please email us if you have any questions. The next monthly live case webcast is on October 25th. We're looking forward to seeing you there again. And then without any further ado, we will move forward to the cath lab to Dr. Krishnan's team. Good morning, Dr. Krishnan.
Good morning, Dr. Guja. We have actually a very exciting case to present. More excitingly, we have our close friend and colleague, Dr. Rajiv Chander, who's the chief of vascular surgery at the VA in the Mount Sinai Health System, who was here for us to help us with this really challenging case. Before I get to the case, I just want to introduce our team. To my right is our esteemed colleague, Dr. Rajiv Chander, who I just introduced. Dr. Sandeep Singla is right here. Ray Lascano, our interventional nurse practitioner. Our nurse today is Marichu and Sarah. And obviously we have Damien, our technician here, as well as our entire AV team. We're also lucky enough to have Ernest, who's helping Damien today with this complex case. Second is we'd like to a little shout out to Elizabeth in Florida. She's obviously from Florida and been taking care of family stuff in Florida. So we wish her well, and we're thinking about her as she's there in Florida. But without further ado, I'm going to go ahead and let Dr. Singla go ahead and introduce this tough case. Damien, can I get a J-wire exchange length?
Morning, everyone. So we have a 71-year-old man today with a known history of coronary artery disease. He had a bypass done in '95. History of CVA in 2016 with no residual deficits. He also has a history of AAA abdominal aortic aneurysm repair in 2004. It was an open repair. And then he presents to us with the severe bilateral lower extremity claudication, left more than right, Rutherford category 3. His exam was unremarkable. Blood pressure, vitals were stable. Next slide. His labs were pretty unremarkable, creatinine of 1.1, and his ABI is the most recent one done in May of 17. On the right side, it was 0.83, and on the left, it was 0.77. Next. He had prior vascular procedures. When he initially presented with the vascular surgery, he underwent a left SFA popliteal angioplasty and a left common femoral endarterectomy in November of 2016. This was followed by a right common femoral and a profunda endarterectomy in February of 2017. He did good. He did good for about 2 to 3 months, and then he started having recurrence of symptoms. That is the time when he did the repeat ABIs. Next. So we brought him back in July, and the hope was to see, what his anatomy looked like and see if we could fix the things. So this is the angiogram from July this year. This is the inflow. You can see a nice abdominal graft without any focal stenosis. Next. This is a cine run on the left side.
Right, give me back the wool.
And it shows a tight focal stenosis and proximal SFA. Heavily calcified, the whole length of SFA is heavily calcified. And there is a 3-vessel outflow below knee. Next. Mm-hmm. This is the graft limb on the right side, which looks normal, and then the whole SFA is occluded, heavily calcified. Next. This is the DSA shot on the right side below knee with a 3-vessel runoff. Next. And this was a DSA shot to show if we had any access options on the right side. Next. So at that point we stopped. We did not want to proceed with the groin access because of the presence of the graft, and he had a very fibrotic groin, which would not even let us put even a micropuncture sheaths, and we had a lot of difficulty last time. So we brought him back with an idea to do this case as a left brachial access. Mm-hmm. So that is what we already secured. Possibly, yeah. And then the next step would be to put a 90 centimeter 6 French sheath. For the lesion in the SFA, we are planning to use directional atherectomy, and for definitive therapy, the first consideration will be a drug-coated balloon. I'm going to stop at this point.
All right.
So yeah, so I would just want to, Doctor, so at this stage, you know, we were very, it's a very difficult situation, obviously. We're trying to figure out how we can revascularize this guy. You know, obviously symptomatic gentleman with significant peripheral vascular disease. So at this stage, we're obviously, well, we decided to go with a brachial approach. And I'm going to just talk to, introduce Dr. Chandler here, because obviously this guy, has multiple challenges that we're facing. Can I get a Grand Slam wire? Multiple challenges that we're facing. So one of the challenges that we're facing is obviously access to treat the SFA. Second is, obviously other options to obviously treat him, whether it's surgical, non-surgical, and what are the challenges posed by the stent graft and in terms of being able to treat this gentleman? Raj?
Yeah. So few challenges that have arisen in this case. First and foremost is the access. The brachial access has to be a little bit higher up. Most of the time we would consider doing a cut down. However, we're going to go percutaneous on this with the 6 French system and hold pressure. In case it doesn't work, we will have to do an exploration at that time and repair the artery. And now going down to the aorta, he has an aortobifemoral
CABG, right?
graft done, and it is a end-to-end graft that was done for an aneurysm repair, meaning there's 2 ends that are connected together, and as the limbs come down, the bifurcations are usually a little bit higher up. There's a stent in one of the limbs that we're going to have to actually get the wire through and put our sheath into, which makes this case very difficult. Again, his other options would be, at that point, would be to cut down onto his left side, which is a reoperative groin like we talked about. It's extensively scarred. There's always a high risk of a wound breakdown. And for him to get a wound breakdown in the groin would essentially mean infection of his aortic graft, which is, it carries a very high mortality with it.
1,000.
Hence, we're going through this and try to do this with the endovascular technique from up top.
So Raj, in terms of bypass options here.
Yep.
So here's a guy who's had a bypass. He's had a Lima to LAD. He's had an SVGs used to both of his things. He's a reasonable surgical candidate. I mean, he's not a bad surgical candidate. What is the patency of PTFE for above the knee in these kind of cases?
The data for 1 year is 80%.
Right.
But data for 5 year goes down to about 60%.
Mm-hmm.
And now, if you look at his previous angiograms, you would probably have to go down. I wouldn't do the PTF on the left side, but on the right side, he would probably need to get something below the knee. So data below the knee with PTFE is very bad. Again, because there's no vein, it's crossing a joint, and you're looking at something close to 60%, 5 years. And we usually reserve that for critical limbs. And
I don't like this.
Really bad lifestyle limiting claudication. But again, the surgery has a lot of, his surgery has a lot of morbidity associated with it because of the fact that this is a reoperative groin ×3. He had an endarterectomy done after he had his aortofemoral graft placed, and which makes it very difficult, meaning there's going to be a lot of scar, and usually when you try to reapproximate the scar post-operatively, it doesn't come together very well. And if he gets, again, a wound breakdown, that means automatically means it's an infection of his aortic graft, and
Okay,
he
so
can need probably a higher surgery.
Mm-hmm.
PK, do you have a brachial subclavian angiography before?
We don't, and I think that's part of the problem here, that we're trying to figure out how the subclavian goes, and you can see there is a big turn here, which is interesting. So again, the worry here is he has a Lima, he has the vert there, he has all sorts of stuff. The reason we went with this is, and I want to just talk a little bit about the equipment. So the challenges in this case are, number one is access. Okay, number two is obviously delivering therapy. And I think that's kind of the importance why Dr. Chandler is here, because now we have multidisciplinary approach where we're looking at this in the real manner, which is, okay, what do we have as options for the patient? So you can see, obviously, in this case, the options are few and far between because of this difficulty here. And you can see the tortuosity in the subclavian is making this very, very difficult for us to treat now. So the issue here is well, it highlights the importance of pre-op imaging in this particular case, which would have helped. But since we didn't have pre-op imaging, the question is now, do we get groin access, go from below, and engage the subclavian, take a subclavian picture, and then come. So what I'm going to do here is I'm going to play the last picture. Can you show me scene minus? Give me a glide wire here.
PK, you didn't, any particular reason why we considered subclavian versus pedal access?
Well, Karthik, I mean, give me a stuff. The problem with pedal access in this is his runoff is what, with the perineal, right?
It's 3-vessel runoff, right?
It's essentially two, peroneal and AT.
Okay,
PT
so the question is, to treat through the perineal, you would have to really give this guy inferior treatment, because the only thing you have available is a Biotronic 4-French system. I would not feel comfortable putting a 6-French sheath. I know a lot of cardiologists put the slender sheath in the perineal. As far as I'm concerned, I think that's kind of overkill in that very, very small vessel, even though it's a slender sheath.
Right.
I really believe that you have to deliver drug-coated technology for this gentleman in order to engage patency. And I think with the newer radial devices that are available both in 135 as well as in longer lesions, I think that we should be able to get through this if we're able to traverse the subclavian. Give me a torquer.
So PK, you think even putting a 5-6 slender through the AT would give you so much trouble? That's
Karthik, I guess I'm old. I'm a little old school. I mean, to me, the problem is that I think this is done far too liberally in today's day and age.
Right.
I really believe that's going in the Lima. I think we should get access below. So we're going to get access below here. Is the groin prepped or no? Yeah. It is. Okay, so we're going to let Ray flush this sheet for me. I'm just going to walk this out, and we're going to go back in.
Do you want to use an 014 system and see if you can traverse it through, PK?
We did. We tried 014 systems, and it's very, very, very tortuous. So I think while Sandeep gets access on this side, I want to just take this opportunity to discuss this. So there's a lot of discussions about I think what they call as PAMI technique, I believe it's called. Is that right? Am I thinking about the right thing here, Sandeep? Is that the right technique, the PAMI technique, right? TAMI. So Braj, a lot of interventional cardiologists really are endorsing this technique of getting transpedal access to go ahead and do SFA interventions. And I just my thoughts are, I know that we have a Terumo slender sheath, which is basically a 5-French sheath with a 6-French inner lumen that you can actually place, and we use those for radial angiograms and things like that. So the issue here is, what the problem that I have with that is that I worry about, especially in a claudican population such as him, who does have options, chances of him losing the limb are less than 5% at 5 years. So the issue now becomes is, do we alter the disease process? Maybe the answer is we don't know, but in your experience, would we alter the disease process by placing a 5-French sheath and then doing transpedal intervention in this patient for claudication?
Prakash, I have very limited experience with the pedal access, but theoretically you could. You are treating a patient who is a claudicant, and now essentially we're trying to, we're trying to go to a healthy vessel and traverse the wire through a lesion. You could theoretically cause a dissection. You could cause a hematoma there. You could cause something that could actually result into an acute limb ischemia, especially if they only have one vessel runoff. So usually over there, I tend to back off. But if he's got a 2-vessel runoff, he might be okay if one of them is actually healthy. If his claudication is that severe, again, doing a bypass into a reoperative field where he's got an aortofemoral bypass. Now, again, my biggest concern is going into that groin. If the groin doesn't come back together, there's a lot of fibrotic tissue. It's essentially a mortality. We're looking at a mortality of close to 60% if his aortic graft is infected. So we're trying to avoid that at any cost, trying to stay out of that groin. So, you know, if it is, his claudication is really that bad, then we go ahead. I think it's reasonable at this time.
To go ahead and do pedal access.
So PK, what I would say is, I know what you're saying. Like if we put a 5-inch sheath into a patent vessel, there's a good chance, you know, there is a 50% chance that you can close the vessel. I think that's your concern, right, PK?
Well, you know, the answer is we don't know.
Right.
I mean, I think the answer is we don't know the natural history.
But let's say you have a case like this, right? You have
Yep.
a case like this where you're going through a subclavian, patient has a bypass, patient has a lima. The risk of causing a stroke and going through a AAA graft or aortofem graft, right? So the risk of causing thrombosis, stroke, right? So if you consider that versus accessing a pedal, you think it's still valid to do this?
I think the risk of having a stroke in a transpedal in a radial graft, as we do in the coronaries all the time, is 0 to none.
Okay.
I think the risk of closing a lima with proper technique, again, is 0 to none.
Okay.
I think that embolization into a vertebral is 0 to none.
Sure.
We do it all the time when we do coronary radials, and
Right.
our stroke rates are so low that it's negligible as
Right.
compared to groin access.
Right.
So to me, I look at the syndrome of what we're going to do. If you see, and I'll show the angiograms that we performed, you can see here that you have a heavily tortuous vessel. The question here is, I don't know where my lima is. I don't know this. So this is more of an example of doing pre-op imaging to be able to
Right.
understand where your access points are before you go ahead and do this.
Right.
I mean, I think if we had a CAT scan, we had seen tortuosity, we would have gone. You could see that it's actually a loop. You could see that the subclavian fills slowly, goes that
Right.
side. But I'm not certain whether that's a subclavian or not. So my idea here is, I'd rather put a 5 French in the groin here, go up, engage the subclavian, inject, give myself a roadmap, and then be able to traverse this across, visualizing where my wire is going, whether it's
Right.
going into the lima, where it's going into the vertebral, or wherever it's going. You know. So I think that to me, you have much more difficulties and chances of closing a tibial and or converting this guy, as Dr. Chandler said, from a. Did you get into the graft or did you get into the native? No, it's the graft. Yep, you're up. You're beautiful. I'd much rather go into the what is it called? Tibial. I think the
big
risks are
incision,
much
okay.
higher in the tibial
There's gonna
than
be a lot
not,
of
especially
fibrotic.
since the
Make a
guy's a
big incision,
claudicating.
okay.
See, if this guy was
Big
CLI,
incision.
and then we have Dr. Chandler here, and all bets are off, that's fine. I am very uncomfortable in today's day and age to go ahead and treat without having a drug-coated technology.
Right.
Second, this guy is very complex. He has even coming from above is going to be difficult because he has a stent in the iliac.
That's right.
As you can see, the one limb thrombosed. We're
That's
treating
right.
the left one.
Right.
So we're going to have to traverse this all the way down through the stent
Right.
and then go ahead and do it. So this is as challenging a case as you're going to get. I'm not certain whether we're going to succeed. This may be one of those where we say, hey, we failed. You know, Dr. Chandler, you're going to have to do the bypass, and then he'll go ahead and do it. To me, to go ahead and get a tibial access, to do non-drug coated technology, and then also more importantly, to possibly not give him or convert him into a critical limb ischemia becomes a problem.
Right.
Now, if Dr. Chandler says, listen, our distal bypass targets are very calcified, there's really no other option, then obviously we would ask him, the patient, to go ahead and do medical therapy. But we already know he's not doing well with medical therapy.
Right.
He's a very compliant patient. He's a very smart man. And I can tell you that it's not working for him. And it's very lifestyle limiting for him. Right. So therefore, I really think that this is going to be the best option to help treat him. If he fails, then we'll consider the others. But I think, especially with the new equipment available, you have both Medtronic and Terumo, which have these longer length catheters, longer length balloons. We know that our DCBs are on a 135 shaft. We have stents on a 155 shaft. And we know that the Zilvers are on 120 or 125. So
Right.
that's the reason we went with the left brachial,
Right.
because we felt that he was short enough for us to go ahead and reach all the way down with drug-coated technology. Give me the vertip catheter,
Rajiv,
guys.
any special measures you have to take while getting the access in the graft?
Well, yeah, that's a great question.
Again, the trackability. You got to. So he's got an aortobifem graft. That's Dacron within his body right now. And now to make things much more challenging, like Prakash said, there's stents within one of the limbs.
Right.
So already there's a challenge. We're going to have to transverse a suture line from up top at the aortic end. Then we're going to have to transverse a stented area where there's Dacron. Normally, it's very difficult to push sheaths through a Dacron that's previously placed, and makes it much more challenging when the stents are there, because essentially what's going to happen, sometimes you can end up behind the stents also. So we're going to be we're going to be very careful over there with that.
And again, that's the whole idea. Let go of the wire. The whole idea is you have a multidisciplinary approach here. Pull the wire back. There you go. Go, Damien.
Right.
Is the table tilted or something?
Yeah.
Untilt the table, please. No, the other way. Is that
So what size of sheath you can put in that graft?
It's usually for the aortobifemoral graft, so it's usually a 16 up top that connects to the aorta, and the limbs are usually 8.
Right.
Right now, but over time, this has happened. It starts to contract because it starts to essentially there's a fibrotic layer around it. It goes down to about a 7.
Right.
Right. So they're looking at 7 millimeters there. So you could probably get away with about a 9 if you really had to.
Okay.
But I have placed 18s and stuff through it too at times
And
for aortic repairs.
And closure-wise, you usually do a manual pull, or do you consider any closure device?
Manual pressure is usually the best.
Okay.
For this, closure devices are going to be very difficult to work into a reoperative groin that's been in there for multiple times. But again, we can give it a try. If it minks, I don't know what you guys. What do you prefer?
Generally, with grafts, we generally pull.
Yeah, and hold pressure.
And hold pressure.
But if you had to use a closure device, what do you prefer?
Call him again. Purge, guys. I'm sorry. If I had to use a closure, I don't know. I think that's a very difficult answer. I think that we would try our best not to use a closure.
Yeah. Yeah. Same here. Usually, most of the time, it's always pressure for both of us.
I mean, I really think fellow seal is a good thing.
Yeah. I agree.
A little die.
So PK looks like the bend is the subclavian, right? Looks like we saw a bunch of vertebral at the end of the shot, right?
Okay, now wait. Why can't I see this? Where am I? Little die. Wow! Look at that tortuosity. Yeah, we are in a world of hurt here. Let's take a picture here. Ready?
Yep.
That's really tortuous.
Go ahead. No, well, let's see. Give me a wire here. We might be able to straighten this out. Give me the glide wire.
Glide, soft.
You're going from below, PK?
Well, no, I'm gonna try to at least get this catheter situated in a point where I can at least give a good injection to see how tortuous it is, and then we can make a decision, and then maybe we go pedal. This is the whole idea. The idea is to sit together, discuss together.
Instead of using, I know you're using a tempo aqua catheter from the brachial, right?
Yeah.
Can you change it to like a 014 catheter or an 018 catheter and see if you can traverse it through the bend?
I don't think it was the catheter. The catheter would have definitely gone. It's more the wire. And something, this is actually a great example of where imaging would have helped us. And I think as cardiology, we don't utilize imaging enough here. And I think this is a classic example of imaging. Now, see, that's going somewhere it shouldn't go. And this is the question here. And the question is whether we should go ahead now and go with a different type of wire here. Let's place it here and give a little picture.
If you
and I think at the same time these cases are great cases, but the bottom line is you need to work together. Can I have a syringe, guys? You need to have a multidisciplinary approach here. And if we're not able to get this catheter across this safely, or if we're losing a lot of purchase by doing that, well then guess what? Then we need to abort. Tell the patient that there's other options that we might have to employ here. At this stage, we've discussed all options with the patient. He's fully aware of what we're trying to do here and accomplish. Little die here. Okay, beautiful. Okay, now, no, don't get afraid. Be not afraid here. You know? All right, guys. I'm a Catholic school boy, so I know all that. Okay. Ready? Inject. Okay. So you can see here that there's the lima, there's a big U curve. But
Right.
again, I don't think this is going to be that difficult to traverse once we get a stiff wire down.
Right.
So why don't you now give me a coronary wire now. Let's use a coronary wire. Yeah, no, give me the Grand Slam. And let's
Give
get
us a
down.
new Grand Slam.
So give me a new Grand Slam. So what I've done here is I've given, how many units of heparin shoot have we given? 4,000. So we're going to give another 1,000 now because I want to keep them heparinized because this is obviously taking longer than we expected. And we're going to go ahead and work on this. So right now
Okay.
we're going to drop this down into this and see whether we can traverse this.
So, PK, when you are going through this kind of torture subclavian, what kind of methods do you use?
Well, I really think first and foremost is exactly what we did, which was the smartest thing. We took our time, we checked our ego at the door, and we said, let's get pedal access. Let's get access down below. So now we have visualization with the flow of the vessel here. So
Okay.
now I can actually see where I'm going to wire, right? So now as this wire goes through, I'm going to be able to see which way this wire is going to go. So I got a nice C loop there. And now you can see I'm traversing the subclavian, okay, if I can. So Ray's going to give me a little bit of positive pressure, and it's still not going here.
I don't think this catheter is going to make that bend, PK, on an 014 wire. You think it's going to?
Well, I think it's worth the attempt. Sir, don't move.
So that's exactly what I was saying from the brachial also. This
Give me
tempo aqua catheter has a stiff tip. I don't think it makes a bend through the 014 wire.
Actually, the Tempo Aqua has a very nice tip, really. You
have more experience than I have with it.
I really love this catheter. This catheter does a good job
Sure.
in making these turns. But you're right. Maybe in this case, I'm going to go with a fielder, and I'm going to go with
Give us a
maybe
regular fielder.
give me a fielder wire, and I'm going to go ahead, or actually give me a glide wire. A glide wire may be enough. A soft glide. This one?
This one in here.
Okay, good. So we're going to go with a
So
soft
Rajiv,
glide.
what techniques do you use to cross this kind of tortuous subclavian?
Exactly what Prakash is doing. I would go to a soft glide. I would be very careful not to dissect into the vessel since it's so tortuous, and go to a 014 system at the end.
Okay.
I would have a very low threshold to stop because again he's got his bypass coming
just pull
off
back
right
slightly.
off of the subclavian over there, and again this is not something I do every day. So
Give me a torque.
Okay. PK,
Nice.
that looks like a lima, right?
I don't know. I'm not certain. If it is, it's actually good if it's the lima. So it is the lima there. So now we're going to go back again, and we're going to give me a torquer here. So at least we know we're in the right part of the subclavian here. So now we're going to go. Remember, you got to take the good with the bad, right? In the sense that this will tell you where you are,
Right.
and at least now, see, that's not where you want to be, and that's not where you want to be.
That's your thyrocervical trunk.
Yeah. Now it's also the catheter is torquing.
Right.
So
That was pretty okay.
there you go.
Now that's again a brachial.
No, it's a little branch, but you're
Yeah.
past the lima here. Well, you may be actually okay. See, you're okay. Huh? It's a little high.
Yeah, because that, as you can see, that
It looks like
concentration-
the axillary branch. So PK, you want to bring the
Give me the
catheter from
torquer.
this side and see?
Not yet. That's a good point, but I took the catheter out because it's in the brachial. So at this stage, I don't want to put anything back in.
So Rajiv, as PK is working, what size of sheath are you comfortable using in brachial without doing a cut down?
Oh, without doing a cut down, I guess I would limit myself to a 6, because then you're holding pressure. But I've seen some of my partners go as high as 9.
Notice?
It's just
Without a cut down.
without a cut down.
Okay.
And this is all manual pressure at the end.
Okay.
Yeah, we're having a little bit of trouble traversing. A lot of times, I think we'll try another wire here. Give me a woolly wire.
PK, you think if you use a Navicross or something, you'll have a
Yeah,
better support?
yeah. I just wanted to get I'm already engaged, so I want to go ahead and get a little bit of purchase and then switch out for the
No, I'm
Navicross.
saying now that you know how the subclavian traverses, why don't you come from the brachial?
I'm actually going to go ahead and now
Make
take
that loop and
another
put
picture.
a Navicross.
I'm going to take another picture. I'm going to hopefully the patient doesn't move, you know. Okay. How long has it been since our heparin? One second, let go.
So, Rajiv,
Yes, sir.
I'll let PK continue because he's going through some. So, what are the things you have to watch out for when you get brachial access?
So let's start from top. Access, you have to be very
Need a
careful with this. You want to be over a bony process so that you can hold pressure later on. Part of holding pressure means, you know, you've got to have something in the back of the artery that you're holding it up against. So the Alcaron process is usually what we prefer, but have to be very patient. You have to sit there, you know, hold pressure. I usually hold for 40 minutes when I do this percutaneously, because imagine if he does get a hematoma there. Now you have a neurovascular bundle within a sheath. The sheath is very constrictive.
Right.
Now, if he gets a hematoma in there, you're essentially talking about you have to explore the whole sheet. You have to evacuate the whole hematoma, and obviously then go ahead and look at whether or not you need to fix a pseudo or so on and so forth into the artery. So if the hematoma occurs right off the bat, be unfortunate, and he can get neurological symptoms, we have to go ahead and explore the sheath at the time,
Right.
which is pretty deep in the arm. Second thing with the brachial access, I am always very careful as I am transversing through the subclavian, going into the arch, as we're going down. There's a lot of times when you're actually working up top, you've got all your wires and everything up. If there's a lot of tortuosity, or if there's a lot of calcium up top, you got to be a little bit careful, because if there's a lot of calcium, it's an old elderly patient, you could flick some of that off. The last thing we need now is an atheroma or a calcified shelf coming down, causing an acute limb ischemia or a stroke, which has been documented. The chances of that happening is very low, but again, we're putting pretty large sheets through this area, and that can occur. And foremost in this case, I would be very cautious. I would have an aortic balloon. We're actually going through his aortic anastomosis, placing a large sheet through it, and that's pretty much about it when I do my brachial percutaneous cases.
Right. Okay.
And now placement of the arm is also very important. I've learned something new from Prakash today. He's actually brought the arm inwards so that he can actually stand on the right side of the patient. In the past, when I've done this, I've always had the patient laying flat and the arm is out, and now I'm all completely on the other side. I'm working backwards. So that's something new for me, and I think that's actually it's very advantageous. And you have to notice the dressing. Look, everything counts here, right? Making it easy for yourself. With the dressing, you use an ioband or something to keep everything in place. Nothing's going to go anywhere throughout the case. So I think that's genius there.
That looks promising, PK.
Yeah, we're definitely across the lima. I'm just trying to get through these little lesions he has. But now I'm just not getting into the subclavian. This is as, how can you say, unlucky as it gets.
I think it's interesting to show what are the techniques to cross. I think it's a great case for us to show what kind of techniques you want to use.
No, I like I said, my threshold is all about the patient, right? I mean, the issue here is, like Dr. Chandler said, give me a wire from the opposite side and let's go from the other side. Like Dr. Chandler said, is now give me a woolly wire. Is that this? He's a claudicant. We abort here. We come back, flush the other sheet right before I go in. We can come back, and then we can do a bypass on him. I just need to make sure that at this stage, that we're going well without having any trouble. Now,
or how about this? Or we can actually do a small cut down right on top of the graft and send stuff down.
Yeah, exactly.
So again, it's a multidisciplinary team. We actually explore every option. And again, now look at what Ray's doing right now. I think this is something new for me. So I'm completely taking my, it's so much easier to get access to the brachial artery when he's positioned this way. His arm is actually coming right into, right where his other groin is supposed to be. It makes it so much easier for us to work.
What's going on? Why can't I?
As opposed to having a supine on the other side of the table. That would have been very, very painful.
Why are you holding? He was comfortable before. What changed all of a sudden? Yeah. So he was very comfortable before off-road map?
Very good.
Off-road, yeah.
Yep. So now, now what we're going to do is we're going to try both. We're going to go above and below.
Right.
And we're going to try to get in.
Rajiv, when you're taking the brachial access sheath out, how do you suggest take it? Just manual pressure?
Yeah, absolutely. Okay. Manual pressure. There's no device that's actually FDA approved for this. I have used in the past a ProGlide when patients have large vessels or they're not good operative candidates, but manual pressure is the best thing you can do here. Okay. And that's what we're going to employ here.
So, Chu, when's our last heparin dose? Okay.
PK, you want to come?
Why can't I move this now?
You want to come LAO and see what's happening there?
I can't move my. Why can't I move anything here?
We are not able to move the II.
There it is. Damien, look out, please.
Come here, man. Break you.
So it's interesting because this wire is in an area which I don't understand where it's going.
It's all curved.
There it is. Now we're okay.
Oh, the right.
Yeah, that's the subclavian.
Then you're going through a longer
See that?
system. That's
okay, good. Now give me the vertib catheter.
Give us a new vertib. Or you want?
No, just take this wire out now.
Okay.
Very nicely done.
At least now we figured out which way to go.
Very nicely done. Look at that loop.
Yeah, it'll straighten out with a stiff wire. All
so
right,
you're taking Navicross now, PK?
Check him out.
Or
was that a company?
No, Navicross. We're doing the vertib catheter.
Vertib, okay.
Okay, once we get access, I want another ACT and more heparin. I want the ACT around 300 on this case, please. Okay, real? So please do not lose. Oh, watch your fingers, sir. I'm sorry. So as you can imagine, it's not comfortable. You know, we just need to keep the patient as comfortable as we can, but it's definitely not comfortable. Right. Push the wire, please. Push it all the way down. Okay, follow the wire. Now show me the heart, please. Okay, make sure it's not going to the heart. Is it going to the heart?
No, it's not. It's in the aorta. You can keep going. Keep going.
It's in the heart.
Yeah,
show
we can always get the catheter down and see.
Okay.
Right.
Yeah. Okay, good.
Now you can.
Now we can torque the catheter. Yeah. Okay, Ray, hold the catheter for me, brother. Okay. There it is. Now we're in the descending aorta. Show me down. Let's just make sure it's not going towards the heart. Heart. So we actually went into the ascending aorta. Hold on, Ray. Pull back a little bit.
You want to pull your catheter from below back, PK?
Yeah, we need to go LAO.
LAO and then pull the catheter down. That's right. And then reorient yourself.
Yeah,
you might be in the descending aorta. You might be just hitting a plaque or something, you know.
No. What is it hitting? No. Are you kidding?
PK, that's not the heart. It could be an aortic aneurysm or something. So you might be in the aneurysmal segment. Definitely not in the heart.
Well, we'll find out in a second, won't we? Okay, give me a little die, guys. Give me a J wire, guys.
J wire?
Give me an exchange length J.
Exchange length J, please.
Okay.
So PK, do you do anything? What size of sheath do you go up to in brachial?
I go no higher than a 7.
Okay. And you're taking the sheath out measures, just manual pull?
Huh?
Manual pull, or do you do anything special?
Always manual pull.
Okay.
By the book.
Follow down now? Yeah, so we're good. Excellent. So we're taking it all the way until now. There's the graft. So this is, I think I am safe to say that this is very, very difficult right now. Okay. Let's see whether we can get in with a J-wire.
Do you use
Very
a,
nice.
do you want to use something like a supracore and CPK?
Well, first I want to get into the graft. So let's now try to get into this graft here. Give me another angle here, and Raj, with his aneurysm expertise, can really help us.
Yep.
Give me a glide wire
So
here, guys.
you're in
Soft
the
angle?
16 portion right now. Now you got to get. Now you're in
There you
in
go.
the graft, but
There.
now you're getting into the iliac stent,
Which is what you
that,
want
which
to
is
be in.
within the graft.
Which is what you want to do, right?
Yes,
Yeah,
absolutely.
Yeah. So
It's
let's.
very challenging, making it look easy, but this is very difficult.
So
But sometimes the wires will not go into the graft to start with. They coil up because there's an anastomotic stenosis up top.
PK, are you going to do anything different here right at this bend?
well,
Or?
right now I'm just going to have to switch to a glide wire.
Right.
So I am going to just take this into this area, and then let me see if it'll advance. Right? Nope, I need a glide wire.
Okay.
Now the problem is, Raj, how do I know I'm not behind the stent graft here?
You got your catheter in there, right?
Right.
And it's not getting stuck?
Stiff glide, guys? No, it's not getting stuck.
You're good.
Yeah.
Because your catheter's in there, so you're good.
Rajiv, is
Yes,
there
sir.
is there a chance you can get behind the stent here?
Oh, yeah.
Okay.
Oh, yeah, especially when they're fresh stents.
Okay.
Yeah. And the worst feeling is when you get behind it, you don't notice it, and you feel a lot of resistance. You usually will feel a lot of resistance, and you keep just sending things down. The worst thing you can do is put a sheath in there. Then the stents start to dislodge.
Hold on, don't do anything.
Right.
Very nice.
Can you torque the catheter, PK? Or?
I'm trying, brother.
Okay.
It's just double bend. I think this.
Right.
Let's see
The
what.
question is the sheet going to go through this?
That's what I'm worried about now too.
Once you
You
get a
know-
stiff wire, I'll go.
You know, everything.
Huh? Yeah.
You might want to
Okay.
consider an Amplac super
There you
stiff
go.
here, PK.
Now we're down.
Yeah.
All right, now give me an Amplat super stiff. Let me go a little bit further. Give me an Amplat super stiff, guys. So now the issue also is, you know, internal iliac, common femoral, all sorts of stuff. See? So where's that? No, that should be okay.
That should be okay, right?
okay.
So Rajiv, how comfortable are you
Can we
putting a
both?
sheet through this stent graft?
I'm not very comfortable.
This is an all repair. It's an all repair. It'll be fine.
You give me an
It's gonna be
Amplat, guys?
fine.
Yeah.
So,
not-
so I
I
just
don't
want to
push
let the audience know. I know PK is proving as if it's not that difficult, but it's actually very difficult to do what he's doing right now.
I mean,
So-
right now, you know, honestly, it's just like I said, you know, everything about this patient has been difficult. Chooch, I'd give another 1,000 of heparin now. You know, you want to keep them anticoag. Oh, Ray, you need to hold here for me. Let's hold that.
So, Rajiv, any other ways? If you're unable to do
Above?
this, you would do a cut down, small cut down, and do
I
it.
think the cut down would be, in my opinion, would be, again, it's easy to deploy for me. So I would prefer to do that. Now his graft, I wish I had something to show you an image of. This graft that's within his body, there's, you know, it is an aortobifemoral open graft. So the bifurcation is much more higher up. It bifurcates a lot more higher up than we know. And it's an acute bifurcation. It's very difficult sometimes to get a sheath up and over. And especially in this guy, it may be almost impossible because he's got a stent on the other side. So
Right.
you're not going to be able to really go up and over because I think some of that stent is going into his main graft, the main body of it, which is actually 16.
So, Raj,
size,
I
yeah.
think now we have to make a decision.
Yeah.
So, at this stage, we're having a great deal of difficulty
Uh-huh.
straightening this graft out. We got a stiff wire.
Uh-huh.
The question is, will a sheath traverse through that?
Yeah, well.
You will. Okay,
will.
so give me it now. Do I have enough purchase on this wire, Raj? This is an Amplat Super Stiff.
It should be good.
Okay.
Just good
So-
bar control will be right.
All right, so then let's go ahead and now get me a sheath, a 6 French pinnacle destination. So now I want to go up and look at my.
PK, you would put a 90
now look
centimeter
what happened to my
sheet.
subclavian.
Very
You
nice.
Yeah,
see
it's
that?
straightened up because the
So
Amplac
now I'm
super
just going to walk this out.
PK, you're going to put a 90 centimeter sheet or?
Yeah, 90 centimeter.
Okay.
Okay. Huh? Yeah. No, actually, no. I'm going to need some help here, Ray. You need to walk that out for me, the sheath out for me on the other side.
Hold on. Yeah, let's get somebody on the other side.
Rajiv, how frequently do you do a cut down, brachial cut down? What is your threshold?
It's 90% of the times.
Okay.
I'll do a brachial cut down.
You think it's just easy to just do? How?
Yeah.
You do it under local?
Local.
Okay.
Local sedation, 1% lidocaine with epi.
Okay.
It's it's essentially a subcutaneous artery, right?
Right.
I mean, I treat it as if it is a subcutaneous artery, right? It's very superficial. It's right in the brachial. The access to the brachial artery is very, very easy for the vascular surgeons here because it's essentially right in the brachial groove.
Right.
You palpate the groove, you get the bicep to one side and the triceps to the other, and essentially cut down right in the middle of it, and it sits right underneath the fascia into the neurovascular bundle. So we do this very commonly, especially for now we have dialysis patients, so on and so forth. We always connect to that artery, and we always do this under local and sedation. Blocks when we want to get a little bit more if you're in the OR, because it makes the patient much more comfortable.
Right.
Here he goes.
Beautiful.
Very nice.
Hold on, sir. Don't move. Keep coming.
Ray's tracking fine. No issues. Okay,
The
over
question
here.
is, are we going to be long enough?
So as we're going through that proximal aortic anastomosis, we'll be careful. It's fine, Ray. No resistance.
Hold on. Go. Go. Okay, stop, Ray. Okay. Brad, you want to give it a? You want to go over there?
Yeah.
Because you get the feel.
So it's important, like PK is doing. It's a multidisciplinary approach.
So you can
As
see.
Rajiv is, I think, more
See right there.
comfortable
You want
with
me to back up?
doing it.
No,
So
that's okay.
Rajiv, you're watching out for any resistance, right?
Yep.
Go.
That's all.
Go.
Yep. It's
I think it's
pushing-
already through,
it's
right?
rubbing but against the stent. That's all. That's it. It's buckling here.
So no good.
It's buckling here. That's it.
Can we do a telescope like that?
Give it a try. Yeah. Go ahead.
You want to
Yeah.
actually let me do
I'll hold
this.
the wire.
Yeah. Yeah. Let me
And I'll
hold
push
this.
as you
Yep.
pull it back, and I'll push it up.
Go.
Yep.
Go.
There you go.
There you
Nice.
go. Go. Go.
Nicely.
Excellent. A little more if we can. Okay. Good. Good. Go. Go.
You're helped.
That's it. We're hubbed. So this is our distance, Karthik.
Hey, Mr.
Yes.
Mayor.
Okay. All right. Now the question is, if we lose the wire, don't move, sir. If we lose the wire, are we going to lose the?
So the sheath is hubbed, PK?
It's hubbed.
It's
It's a
hubbed.
90 centimeter.
Wow.
We should be okay. We're
Okay.
still in the proximal anastomosis. Give me the vert tip catheter now.
This is probably good. You don't have to go through
nice
that
image.
bend, you know. It's like
Well,
I mean,
but the
you
equipment
almo-
has to go through that bend. Vert tip catheter, guys. Ray,
Yeah.
come back
Oh.
here. Okay, let's actually, Ray, before you come here, you flush that sheet. Okay. Actually, you know what? Give me a Terumo Navicross now. Flush the sheet. Terumo Navicross.
Give me like another 20.
So PK, you're going to do what kind of? How are you going to treat this? With atherectomy and DCB or?
So again, see, now we're dealing with length issues.
Right.
So the Terumo is now 135. This is 90.
Right.
So, let's see. Let's see how far we get.
This is a proximal SFA, right, PK?
This is the proximal SFA.
So I think you'll be able to reach all the equipment until there, right?
Well, let's see. God willing.
So if you are, you're going to use directional atherectomy?
No, definitely not.
Okay.
Definitely not. Here, Roger's going to track this now. Rail, please. No, we don't have wire yet.
Okay, the wire.
Go,
wire?
go, go. Yep, here we go. There's the Navicross now going down. Any resistance?
A lot.
A lot of resistance. So this is another issue here.
Yep.
So the question is the bias. Go try any issues?
It's
No?
there we
you
go.
So what I did there was I pulled the wire,
Yeah.
got
Took the
Raj,
took the
got
wiring.
rid of the bias for Raj, and then I'm going to advance the wire. Go.
Easy,
Go.
easy.
peasy.
You're good.
Okay, Pete, a little more.
Again,
more.
those were
There
the
you go.
stirge
There
that
you
we
go.
were talking about. Now
Excellent.
notice right there, that's the anastomosis we are just going through now.
That's enough. Yep. So now I'm going to take a picture for us to get an idea. Now the sheath is flat. Now can somebody do
I flush it.
can somebody do an ACT through the sheath for me? Oh, the groin sheath. Pull out the catheter in the right groin for me.
That's fantastic.
Yep. Pull out the catheter in the right groin. Just whip it out. Yep. And then let's flush the groin sheath and do an ACT. So, you know, for everybody at home, it's really multi-vessel management here. You've got stuff going on in the right side. You got stuff going on the left side. You need excellent nursing care, excellent techs, and, you know, we've got the best here at Sinai. So, you know, the whole issue here is, you know, the nurses are reminding us about the ACT. They're keeping an idea about what's going on in the sheath. You know, Ray's flushing the sheath for us, making sure that there's no issues. Now that the quote-unquote easy part is done, now we're going to go ahead and now do the intervention. So flush forward, please. No Angiomax because we got plenty of heparin in here. Now let's take a picture. Rod, you can step aside, brother. I don't want you to get radiated already more than you have. So now we got a good pressure, and now we're going to decide what to do. Now there's going to be a lot of oohs and ahs in the room when we see this, but you know, there's always interesting stuff, you know. So let me get this off. Okay. All right, Mr. Myers, don't move, sir. We're already almost done here. Okay, no problem. Inject. Beautiful. Okay. Wait.
My repair looks good.
Inject. There's the lesion right there. And this is the work that was already been done. So, you know, again, we're choosing the right case for the right type of device, right? So this is he's more symptomatic in this side. I want DSA. And we've been able to get it down to this level for him. And
PK, do you know the ACT at this point?
Actually, Marichu and
What?
Sarah are running it. So, again, now I want everybody to
CT
know
was on the
this,
other
okay? So Dr. Chandler has already done the difficult part. He cut down when he did the bypass and he angioplasty this. The patient had recurrence of symptoms on this side.
Yeah.
So therefore, see, we have a focal lesion here, and it would have been a shame to be able to actually cut this down to do this, you know, in the manner that we talked, okay? So now you can see here, he's got a focal lesion, easily reachable. And, you know, again, a lot of times, you know, when you're training, you tend to have TIAs. And Sandeep had a TIA. He forgot to mention this, that we actually had fixed this. So that's why we were talking like we had a long CTO, remember? Whether we have enough length, this, that, or anything. But again, it doesn't matter. So now we're ready. Now we can go ahead and cross the lesion. So I think, Raj, now you would agree this is the right thing to do. With this,
Yeah, absolutely.
rather than do a cut down. So,
Absolutely.
So again, I want everybody at home to send money and gifts to www.sandeepsingla.org. He needs a lot of rehab. So we are now going to go ahead and fix this.
I think you're taking care of that.
No,
PK,
actually,
so.
I'm a lot better than Dr. Chandler. Dr. Chandler is actually quite, how can I say, vocal in reprimanding the fellows. In a very good manner, politically correct, vocal manner.
More than
but
you?
But the fellows
More
are
than you?
reprimanded and they understand exactly what he thinks.
No, more
I don't
than
think
you?
there's ever a doubt
Wow.
on whether the fellows understand
We'll
what
let them
Dr.
know.
Chandler thinks. All right, guys, give me now a
So
035
PK,
supercore.
what ACT are you aiming for? Because your
We
sheath is in a
want
graft,
over
right?
300 here.
Okay.
I have no doubt that in my mind that Sarah is not going to allow me to get away with less than 300 because the guy has a lima to LAD. We're across the lima. He's very, very fine and stable at this stage. Flora, guys?
So PK, I think we all understand this this lesion, how it's done and everything. I think the more important thing is to talk about how to deal with the sheath when it goes to the graft. What are you, Raji? What are you watching for while doing the intervention? You know,
Is
what
the
are you
wire
things you're watching for? No, it's not out yet.
Definitely, there's a lot of tortuosity. There's a
coming
lot
down.
of bends and curves that we're going through. You know, at any given time, the sheath can kick back.
Right.
That's one thing that I'm always afraid of. But now that we have significant amount of purchase, I don't think that's going to happen. We're always going to keep an eye on his brachial axis also. You know,
Right.
at any time it can start shearing too.
Okay.
So we're
good.
you know, we have that in our view again
Good.
with the
So now-
whole setup this time.
Can
I
we
think
have a
it's,
DCB, guys?
fantastic.
Flora?
And
So now,
Pretty
in
much
this
it.
case, Karthik Bhai, I'm not doing atherectomy. I've got a 6 French sheath in, you know, and again, we demonstrated all the challenges that you can have. A little more out, please.
PK, I'm just saying, like, if I know you're doing a DCB here, right?
Without and to me, Karthik, if you came up from the toe, you know, will you have a short DCB, guys? A 6 what? Actually, you're going to have to cover up to the ostium, right, Raj? What do you think?
absolutely.
Right? So maybe give us
More
an
the
80.
merrier.
So
248. Give 2,000 of heparin, please.
so
Ray, give 2,000 through the sheath.
So
No,
PK,
Ray's going to give it.
I'm just thinking, like, if you're doing a DCB here, right? Just off-label, I mean, just plain old DCB. So now, if instead of doing DCB, you can put a short Zilver, right? Zilver PTX.
You know what? Okay. If you look at the patencies we have available, right?
Right.
In this type of lesion, it's a vanilla lesion. It's an 80 millimeter lesion. Yeah, it's involving the ostium. I do agree. So the DCB data with Impact SFA
Right.
out to 4 years, which is just recently.
Right.
I was supposed to present it at Cersei, but unfortunately I had to come back because Raj wanted me for this case. I wanted to stay in Denmark. By the way, I want to let everybody know that Dr. Chandler doesn't have any heart. But anyway, the bottom line is, the doctor, my good friend Dr. Mickery, presented it, and it basically showed sustained patency out to 4 years at 65% primary. So in these vanilla type lesions. Okay. So in these lesions, like we're talking, I mean, if we can get away with a DCB alone strategy, I think it's the right thing to do. Flora, please.
Right.
So you can see here that we're going down, again, a lot of resistance. I need a real rail, guys, here.
So PK, we're getting a lot of questions regarding the complications of putting the sheath across, the subclavian complications.
Fuck. Yep, go ahead, shoot.
So I think the questions being asked is, they're asking about the dissection in the subclavian. Are you concerned about it?
I am not concerned about dissection in the subclavian because I don't think that I will be anywhere near going through the subclavian. Put me on coronary. The only time I'd be worried about dissection is if, like Dr. Chandler said, if we have a wire issue. And if we have a wire issue, then I would clearly be worried about subclavian. So that's why I think we got accesses below. And then we came from below and above and actually visualized the wire going through. So
Right.
now you can see that this kink that Dr. Chandler said is quite significant. The DCB is not going by. So what I'm going to do here is I'm actually going to lose. Where's my wire? Is that my DCB right there? Okay. I don't know why it's not making this turn, Raj.
Yep.
So PK, you can put the DCB and pull the
Maybe
sheath
I'll pull the
back
wire
and see
back?
if you can.
Yeah.
Pull it back a little
I'm
bit.
going to have to lose a little wire here.
There we go.
Okay, try now.
No.
No. There it goes. A little bit now. No, there it goes. Now you got it, Raj. Good. Good. So Dr. Chandler now has pushed the DCB through. Now we're going to have to probably rewire this, which we will. Again, it's really, as you can see, it's a two-man job. We're watching the sheath. We're watching the DCB. We're watching everything. Okay, now let me see down below. Let me see how much my purchase is. I'm still across. Raj, if you can just get it down.
Going down.
Uh-huh. A little more. Keep coming.
Again,
PK
this is what we were talking about. This is the Dacron graft, and we're pushing things through it. It's very difficult to do so. You're always going to get this resistance that we talked about. Tell me
A little
when.
more, Raj.
Prakash.
A little more. I don't know where it is. We're going to take some dye. Ray, give me. Let's flush this. Give me. Let me withdraw through the
You can
sheet.
inject through that, PK.
No, it's going to be very hard to inject through this because this Impact DCB is quite large, and I think my Impact rep
I
is
think
outside cringing right now.
If you're not, okay, if you didn't change the angle, you can go by the previous picture and see
Yeah,
the
see,
numbers.
you can't even withdraw any blood out of here.
Okay.
So I think we're going to have to go C minus here, and let's look
I
at
think
our
it starts from 15.
minus. Show me the ostium, guys. Minus. 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 Right there. That's it. Plus. Okay, so it's actually 15. Excellent.
Right.
What Karthik said. 15 to 24.
You can go to 24.
Okay, so let's see where we are. We're
you can
at
go
15.
you can go just below 15 also, PK.
You have to go down a little bit,
yeah,
Raj.
you can go just below 15
No,
and
we're
then
going to have
it
to
at
go down a
25.
little more and more. We have no lesion at 15.
Right.
Is it? There you go.
Right
Good.
there.
Now, show me down. Yeah, we got the lesion now. Now let me see where this wire is.
It's probably there.
Let me
You
just
just
push
have to
the
push
wire
it down.
forward.
And let me.
There you go.
Don't burn yourself.
All right,
right?
PK,
Okay, good.
the other questions being
Want me to do
asked
it?
here
I'd
is,
go a little bit more, bro.
Okay.
Slightly. No, push the wire down. I mean the balloon down.
Oh, balloon.
Slightly.
I think that sounds pretty,
That's good right there.
That looks
Yeah,
pretty
I
good.
want to get to 25. So now, as the Marichu checks on the patient, we're just going to go up here with the balloon slowly with a timer. Ray, can you transduce the other sheath, please, so I can get a pressure? So you can see here's my balloon going up, right?
I think
and
you
there's two
covered the
lesions
lesion,
right
yeah.
there. So there's our
Very
tight
nice.
lesion. So now I'm going up slowly. And
So PK, the other questions asked here is, are you going to take picture of the subclavian at the end of the case?
yes, I will, of course.
Okay.
Absolutely.
Are you going to take?
I have a lima there. I have dual access, so now I'm up. So the idea here would be just to leave it at this and then be done with it. If we need to stent, we can talk about the mechanisms of DCB failure, which we don't know. I've been asking all the companies to provide us some of the data to be able to look at the mechanism of failure. So we actually don't know how these DCBs fail. We don't know if there's a flow-limiting dissection should be left behind or not left behind. I'm going to ask Raj what his thoughts are on this dissection, and then we'll decide. Hopefully we don't get a dissection. We get a nice, beautiful result. The other question is the use of ancillary IVUS. Obviously, in this case, we don't know the IVUS part of it because it's very difficult. I don't think the IVUS would be a smart idea to track an IVUS through this and then get into antecedent issues with the 014 wire, et cetera, et cetera. But I think if in DCB use, I think IVUS is going to tell us a lot. Is everything okay? Thigh, okay. The IVUS part of it is very important because the IVUS may tell us whether we have prohibitive calcium, whether we have other types of calcium, et cetera, et cetera. So at this stage, I think we're just going to do a DCB, do a nice picture, do a nice runoff, and hopefully walk the sheath out, check the subclavian through the right groin, make sure everything looks good, and then we'll be out of Dodge. Again, it's a case that has so many complexities from decision making on access points to obviously how you're going to technically traverse the case to how you're going to technically do it. But the take-home points here, my learning is very simple. I should have done imaging of that subclavian. I think Raj would agree with me here. I think that is a huge important part of this, especially in a patient with atherosclerotic peripheral vascular disease. I mean, we knew the subclavian wasn't occluded because he has a lima and he has no ischemia, but yet the tortuosity is prohibitive, and therefore we have to do it. Second is since we didn't do it, you want to now, you saw all the different steps that we took in taking care of this. Third is proper information. Obviously, Dr. Singler gave us wrong information by showing us the old angiogram. But again, I'll blame him because he's my fellow. But at the same time, I think that's also important because it actually turned out to be happy news rather than a 200 millimeter occlusion, which would have been very, very difficult for us to treat from above. So, I mean, in some ways, it worked out for the best. Now, Raj, question. We know everything restenosis.
Yep.
This is a focal lesion. Hopefully it doesn't restenose.
Mm-hmm.
If it does restenose and he remains a claudicant, what are our future options of therapy? Or that's my question. I mean, we're giving him the best possible therapy here,
absolutely,
right? Which is drug-coated balloon. But if he does restenose, what are we going to do?
It's pretty close to where it's really easy to access the SFA over there. I would actually prefer to cut down right on top of the SFA and do a little patch angioplasty onto it, meaning sew a little patch onto it, as we do in the carotids, and make it and fix the problem that way, because it's not going deep into the thigh at that point at all. And it also, most importantly, it keeps us out of the reoperative field. Because he hasn't been up. Yeah, absolutely. So we've done a few of these, yes, some disasters in the middle of the night. Remember, we try to stay out of the reoperative field. We just, sometimes if we have to get access to the vessels, we go ahead and cut down on the SFA. And so we've had some great results.
So we've been up for 3 minutes here, Raj. So if you can help us walk this out on the other side. Again, it's the whole, two-member thing here. So so Dr. Chandler is going to walk it out because I'm going to go AP here. I'm going to show him the sheath. And once the balloon is completely down as it is now, we're going to watch the balloon in the sheath. You want to walk it out? Go ahead.
Yeah.
Okay, so he's going to walk it out.
I'm going to have to hold the sheath.
All right,
the
then let me walk it out. Yep, let me walk it out.
I got sheath.
So it's going to be very tight, as we know. It's a very big balloon.
Yep.
Okay, and it is really, really tight,
so
guys.
You feel that's all Dacron that you're like pushing things through.
My gosh, show me above.
Yeah.
Show me above. So very, very tight, as we see. So now this is the area where we had trouble, and there's the pop. So now we're through the Dacron, but I still want him to stay there. And then once we're out, we're going to do a nice DSA shot. So Ray, can you flush that sheath for me over there on the other side? And then actually, you know what? Let Dr. Chandler flush the sheath. And then we're going to go ahead and take a picture. Is that pain in the thigh gone, sir? Actually, we'll draw back some blood. Yeah, there you go.
Yeah, I got it.
Oh, you got some air. Okay.
So PK,
come forward with a little dye. Mm-hmm. Good. Okay, pressure's good. So Raj, step aside, buddy. Let me just give you a picture here.
So PK, a question. So I'll ask the question after you take the picture. So
yeah, let's take a nice picture here. And
After you take
hopefully
the picture, I don't want to jinx the procedure, but I'll ask the question after you take the picture.
Well, again, you know, I think it's also case selection and looking at everything here and seeing how everything looks. And I think we're done.
Great. Okay.
I think we're done, Karthik. I think this is a beautiful.
So, PK, I'll ask you a question now that we took a picture. It's calcified lesion. You know, you can perf any lesion. So let's say you perf this lesion. What is your options? How would you deal with it?
I think most of all of us here know that we work on Angiomax most of the time.
Right.
And Ray and Marichu this morning were like, well, we're going subclavian. Let's not go with Angiomax. And I think it's right. And I think that's part of being a team, right? We look out for what are the complication management. I think in this case, very, very clearly, we can reverse the heparin. And again, like I said, we have Dr. Chandler here, right? And if we need to cut down, we need to do something, you know, we can do it. Now, the covered stents, I'm just going to look outside and ask my team, what is the length of the covered stents? But we have all different covered stents.
Right.
My worry, and I'll talk to Dr. Chandler about this, is how will that covered stent track through this type of
That's right.
you know, graft?
That's my question.
So, you know, we'll let him answer that because obviously he has more experience with that than I do.
Yeah, cover stents are very difficult. I wouldn't track a long cover stent. It would be a focal tear,
Don't move,
hopefully.
sir. Don't move, sir.
You usually do this. This is something we do all the time when we do our fenestrated grafts. We place a stent through the graft into the visceral artery to get the fenestration going. So at that point, normally a 622 stent going through a 6 French sheath would be just enough on an atrium. That's what that would be my go-to for multiple reasons, because it can go through a 6 French sheath and it's an atrium. You can expand it as for as long, you know, it's precise deployment.
So would you
and
do
also,
what about an atrium in the proximal SFA, Raj, in that situation?
I think that would be
excellent.
that would be the only thing to go for. I mean, it's going to be a focal tear. It'll be a small atrium, a 22, and it would fix the problem right away.
Okay, got it.
and you don't have, Raj, you don't have any issues
beautiful.
of going a covered stent through a Dacron graft?
Excellent, we're done.
I do. I think, again, the 622 would be fine.
6.
Anything we go larger would be a problem. Like, look, the Viabonds, you're going to have to upsize the sheath, right?
Right.
So you're essentially left with something that will go through the
6
sheath
French.
that we have right now.
Right.
And I think the atrium would be just fine.
Okay.
That's usually my go-to whenever we get
So
any
give me
kind
a
of a
dilator,
perf, because
guys.
we can go through the similar sheath at the same time.
So
PK,
Karthik, so now we've done our runoffs. There's no flow limiting dissection. We're done. And I've just heard from my crack team here that the atrium length's a 120.
Right.
Excuse me, the Viabond length's a 120, and the atrium, as Rod's saying, is maybe the better thing to do here. For us, you know, the idea.
PK, I'm
Yes.
sorry. Before you're taking I know you're putting the dilator. Would you want to pull the sheath back and take a picture of the graft
I mean, you
and
could.
graft and see?
I mean, his
from the aorta?
creatinine is creatinine is 1.3. We had no trouble transversing the aorta.
Okay.
Thank God so far we've had no issues with blood pressure.
Okay.
We've, you know, I've got a wire across this if I need issues. I've got my vascular surgeon in the room. I'm ready for a OR kind of situation. I mean,
Okay.
we've taken all different precautions into play here.
Sure.
You know, at this stage, no, I'm not going to trend it unless both of you feel very strongly, and Raj doesn't either, that we need to take a picture at this stage. I mean, we had no trouble crossing that graft with the wire. If the wire had gone behind it, if there was any issues, you know, then I would agree. But at this stage, we don't need to.
No, it's a question being asked.
Sure,
by the
no,
email.
real. So Raj is going to take the dilator down, and I think this is very important, as you can see here. Put me on coronary, please.
You got me?
Yep, I got you. And you can see here that this is going to be important to help us pull this graft out carefully. So you can see here he's coming down. The dilator is going to come through slowly, and there's the dilator through the graft. Now he's just going to do a two-handed technique. Let me hold the brachial if he wants here, right?
It'll be okay.
You're okay?
Yeah.
Okay, go ahead. So I'm just going to put negative pressure on the brachial. He's having a little bit of pressure in that spot, right? So now, okay, now he's out of the graft. So now, Raj, should I pull the wire back so we don't have much tension on the wire as we pull it through the
It
graft?
should be fine. Yeah.
Right,
Whatever
so I'm just going to pull the wire back slowly.
You take over so you don't burn.
Yep, hold on, there you go. So the wire's back now. So now I have all the tension out of the graft. Now Raj is going to just go ahead and pull it back.
You want to take it? I'll just hold so
Yep.
that way you won't burn.
Yep, okay, so I'm just going to do it
Yeah.
without any,
Yeah.
just a little bit of radiation.
Good.
Okay, now I'm just going to walk it back till I get to the subclavian. And
Okay.
Chu's going to cycle, or Damien's going to cycle a cuff for me.
How you feeling?
And then And
This?
now I'm
Where
going to
does it
just
hurt?
come across this.
Where does it hurt?
I think that's enough, right, PK? You
Well,
want to take the
Where
picture?
did it hurt?
No, I'm
Where?
gonna
You're not
cut-
taking the picture of this subclavian?
Well, I'm going to take a picture from below,
Chest.
Karthik. I'm going to leave the wire across it, and I'm going to come up from the other side and take a picture.
Did it stop?
Because remember, the flow,
Everything's
give me
fine,
the
fixed.
new vert tip, guys. The flow across that subclavian is going to go, he's got a blood pressure around 170.
Right.
I'm going to leave it right there, Raj. I don't want to just take a picture. The blood pressure on 170 is going to
Chest
allow
down,
me to
chest being
visualize
down.
the subclavian much
Chest being
better
down.
from below.
Okay.
Is
Flush?
your chest pain down?
Yeah.
Good. It was just taking a sheath out.
Okay. Yep, wire now, guys. Give me a woolly wire again. And again, you know, the whole idea here is to see how things are doing. Remember, this is likely overkill, to be honest with you. I'm sure Raj would agree,
Yeah.
because, you know, we had no issues, but I guess for demonstration purposes, we'll show. You know, we did have difficulty, but remember the wires we chose, Raj, you can move so this way you don't get radiated.
Yep.
We're just going to leave it there. We're going to leave
Just
the wire
keeping it in
down
my
at
hand.
this stage.
Okay.
He's not bleeding or anything,
No,
is
no,
he?
no, he's not. I just don't want it to torque. That's all.
Okay. Get to a track, Ray. So
I'm
Raj
fine.
is just going to stay there
Yeah.
for a second while I just take a quick picture, because Karthik is really insisting we do this. Okay, right there. That's good. That's good. Yep. So now
That's a question being asked, PK.
I'm teasing, you know that.
So, Raj, the way Raj and PK, I know you guys just do a manual pull. The way I do brachial pull is I put a blood pressure cuff.
Uh-huh.
I go to more than diastolic blood pressure on the cuff, leave the cuff there, and then do the pull.
Come forward.
Nice.
So I let the cuff do this work. So the amount of hematoma formation is much less
Uh-huh.
because you're doing proximal compression. So I leave
Careful,
the
Raj.
cuff for about 10 minutes.
Just coming toward
Then
you.
I go back to 50% of that. Then I do it for 15-minute hold. Then
Just leave
after
it there,
that I
yeah.
put a small pressure cuff. You know the balloon pressure cuff we put it for femorals.
Yeah.
I put that there for
Okay.
about 10 minutes and then take it out.
Learn something new every day.
So
Pressure,
it
yeah.
works very well. At least for me,
450?
it worked very well. So
Yeah.
Yeah. Probably DSA.
PK, thank you for taking the picture. We really appreciate it.
No, you know, as always.
Everybody from the audience and Dr. Guja
One
appreciates
second.
it.
Sir, just hold your breath for a second. Go ahead. So you can see the lima is filled, right? And you can see you have excellent flow in the subclavian, right?
Yeah.
The tortuosity, I think that's just a wire bias that you have, so we're done.
Yeah.
Right, the most important thing is to show flow in the lima,
Right.
and you can see there's your lima filling right there,
Right.
right? So I think you're fine.
I think we're good.
So we're going to walk this out, and then we're going to let, okay, we're all done, sir. Can I have a short 6.5 sheet?
That's a great demonstration, PK.
Thank you.
That's
I'm just now.
nice job. Rajiv, nice job.
Thank you.
So now what I'm going to do is, while the sheath is there, I'm going to pull this wire across the lima and get it out of there, because I don't want to, I don't know, Raj, you think that's overkill, or just go ahead and leave the wire where it is?
I'd leave the wire where it is.
Okay, we're going
just
to leave the
if
wire
you get
where it
access
is,
issues.
and I'm just going to walk this
Yeah.
out, and he's going to bleed back, and then we're going to load the
short
short
sheath.
sheath on.
At this point, I actually give more credit to Ray,
Okay.
Sandeep, Chu, and Sarah, because I think they are doing most of the job. PK is just getting a nice radiation and getting a shine on his skin, as usual.
It's the idea. That's how me and Raj look
So
so
that's
young.
how PK stays young. I just want to let the audience know he gets a lot of radiation.
Okay, let's
You're good.
walk the
He
dialer
doesn't have to
around.
get the Botox that way. So,
And the wire,
Ah.
and the sheath and the wire out.
so the wrinkles go to the fellow and Ray. So that's how
You
it
want
is.
the wire
There's a
too?
lot of tension, see? That's what I was worried about.
Alright,
Okay.
so,
So guys, this is very important. Now look at this. So what's happening is there's a lot of tension. So what I'm going to do is I'm
where's
now
the
going to use a catheter. I'm going to take a catheter across the tortuosity, because remember, we've straightened out that tortuosity, and I think that's what's important. So now what we're going to do is we're going to take a catheter, put it in the descending aorta, and we're going to pull the wire through this catheter, which is going to avoid what I call as a cordoning of the artery. Because remember, you have a lot of bias when you straighten something out. So this issue, that can also result in
got wire?
dissection. So now Dr. Chandler's just going to take this across into the aorta, like right, a little bit more, like right there. And now what I'm going to do is stop there and just pull the wire. Now it's very smooth. See, now the wire is very smooth. Now at this level, I'm just going to leave the wire in front, and I'm just going to pull it back and out of the vessel.
Nicely
and
done.
that's it. So now we're completely done. Case over, you know, and I think, you know, hemodynamically stable, doing very, very well. And it took till 9:30. So again, this is a case that's
How
too
does
much
your
to
left
talk
arm
about.
feel?
But I think, I just want you guys to watch online and send us your questions. And more importantly, we'll see you next month for the next one. Okay, so again, I appreciate Dr. Chandler taking time out of his schedule. As I said, he's the chief of vascular surgery in the veterans system here in New York, especially in the Bronx. And I really appreciate him coming here and helping us with this very, very difficult case. Again, I thank our team and everyone involved. Again, guys, remember in these kind of cases, everything good? Yeah. Okay, multidisciplinary, number one. Number two is understanding your access points, okay? Number three, understanding the equipment. There is radial equipment available. A lot of people want to do radial for every single case, but I think that, when you have a femoral access and you can do a femoral very easily, I think a radial should be, is a viable option for any case. But I think this is one of the cases where I think radial saved the day, prevented a major issue with cut down and re-op and so on and so forth. So again, I thank you for your time, Dr. Guja, and great case, guys, and thanks, team.
Great job,
Thank
guys.
you.
Great job. Thank you.
Great.
Nice
Thanks,
job.
Rod.
All right. I hope you guys all enjoyed the case. Had a interesting things to learn about. I think PK was very explicit about what are the complications to watch out for when you do from the brachial axis. It was nice of Dr. Chandra to join in and give a surgeon's perspective. So we look forward to seeing you again on October 25th. If you have any questions, please do send us. And this case will be on the archive list in about a week. And at any point, if you send in questions through peripheраlinterventions.org, we'll be more than happy to answer it. Looking forward to see you again on October 25th. And see you guys. Have a great day.